If you're turning 65 in the next few years and haven't figured out Medicare yet, you're not alone. But the clock is ticking. According to the Kaiser Family Foundation, roughly 11,000 Americans turn 65 every single day. That's 11,000 people facing the same confusing alphabet soup: Part A, Part B, Part C, Part D, Medigap, Advantage. And no one handed them a decoder ring. Pick wrong, and you could face lifetime premium penalties that never go away. Pick right and you lock in coverage that protects your retirement savings from one catastrophic medical bill. Today, we are decoding all 4 Medicare parts, what each one actually covers, what each one costs in 2025, and which combinations make sense for most people in their 60s. Let's start with Part A, because most people assume it's free. And for most people it is. But free comes with conditions. Part A covers inpatient hospital stays, skilled nursing facility care, hospice, and some home health services. If you or your spouse worked and paid Medicare taxes for at least 40 quarters, that's 10 years, you pay no premium for Part A. According to CMS, about 99% of Medicare beneficiaries qualify for premium-free Part A. So, for most people watching this, that box is already checked. But here's what most people get completely wrong about. Part A. Free premium does not mean free coverage. Part A has a deductible of $1,676 per benefit period in 2025. Note that. It's per benefit period, not per year. If you're hospitalized, discharged, and then readmitted more than 60 days later, a brand new $1,676 deductible kicks in. That can happen twice in one calendar year. And if your hospital stay runs long, the cost structure gets steep fast. Days 1 through 60 are covered after that deductible. Days 61 through 90 cost you $419 per day out of pocket in 2025. Beyond 90 days, you tap what Medicare calls lifetime reserve days. You only get 60 of those for your entire life, and each one costs $838 per day. After you exhaust those, Medicare pays nothing. That is not a small number. A 3-month hospital stay in that last tier could cost you over $75,000 out of pocket before Medicare pays another cent. This is exactly why most people pair Part A with either a Medigap supplemental policy or Medicare Advantage. We'll come back to that. If you do not meet the 40-quarter threshold, you can still buy into Part A. In 2025, people with 30 to 39 quarters of work history pay $284 per month. Those with fewer than 30 quarters pay $518 per month. That is a real cost, and it matters for people who spent years out of the workforce. Caregiving, self-employment gaps, or immigration history can all affect your quarter count. Check your Social Security earnings record at ssa.gov before you assume you're in the free tier. Part B is where most people feel the sticker shock, because unlike Part A, everyone pays a premium. Part B covers outpatient care, doctor visits, preventive screenings, lab work, durable medical equipment, outpatient surgery, and mental health services. In 2025, the standard Part B premium is $185 per month. That is what most people pay, but most has a specific definition. It means people whose income 2 years ago was at or below $106,000 for single filers or $212,000 for joint filers. If your income was higher, you pay more through a surcharge called IRMAA. We have a dedicated video on IRMAA coming up in this playlist, so I won't go deep on it here. Just know the income thresholds exist, and they look back 2 years, meaning your 2023 income determines your 2025 premium. Beyond the premium, Part B has an annual deductible of $257 in 2025. After that, Medicare pays 80% of approved costs. You cover the remaining 20%. Here's the number that should grab your attention. There is no out-of-pocket maximum under original Medicare Part B alone. None. If you have a serious illness requiring frequent outpatient treatment, dialysis, chemotherapy, intensive physical therapy, the 20% coinsurance can compound into tens of thousands of dollars with no ceiling. That is the coverage gap that Medigap policies exist to fill. My take, if you are in original Medicare, meaning you chose Parts A and B without a Medicare Advantage plan, you almost certainly want a Medigap policy alongside it. The monthly premium for Medigap varies by plan letter, age, and location, but the catastrophic protection it provides is why I'd prioritize it over cutting that cost. Part C is where Medicare gets genuinely confusing, because Part C isn't really a separate layer of benefits. It's an alternative delivery system. Medicare Advantage, the formal name for Part C, lets private insurance companies deliver your Part A and Part B benefits in a bundled package. You still must be enrolled in both Part A and Part B to join Medicare Advantage. You still pay your Part B premium, but instead of Medicare paying providers directly, your Advantage plan does. According to CMS, more than 33 million Americans were enrolled in Medicare Advantage plans as of 2024. That's over 54% of all Medicare beneficiaries. The growth has been enormous, and the marketing is aggressive. You've seen the TV ads promising $0 premiums, dental, vision, hearing, even fitness benefits. Here's my honest read on Medicare Advantage. The extra benefits are real, but they come with trade-offs you need to understand before you sign up. Most Advantage plans use provider networks. HMO-style plans require referrals and restrict you to in-network doctors. PPO-style plans offer more flexibility, but still cost more out-of-network. If you travel frequently, spend winters in a different state, or have established relationships with out-of-network specialists, an Advantage plan's network can become a serious constraint. The other thing to understand is prior authorization. CMS data has consistently shown that Advantage plans deny prior authorization requests at higher rates than original Medicare. A 2022 HHS Office of Inspector General report found that 13% of denied prior authorization requests in Medicare Advantage would have been covered under original Medicare. That doesn't mean Advantage is bad. For many people, especially those with limited budgets who need the zero premium structure, it's a reasonable fit, but go in with eyes open. Your health history, your doctors, your geography, and your tolerance for network restrictions all change the math here. Part D covers prescription drugs. It's offered through private insurers, either as a standalone plan added to original Medicare or bundled into a Medicare Advantage plan that includes drug coverage. In 2025, Part D got a significant structural change thanks to the Inflation Reduction Act. The catastrophic out-of-pocket cap for Part D is now $2,000 per year. Before this law, there was effectively no cap. Beneficiaries with high drug costs could spend far more. This is a big deal for anyone managing expensive chronic conditions. The standard Part D premium varies by plan, but the national base beneficiary premium in 2025 is approximately $36.78 per month. Your actual premium depends on the specific plan you choose, and the late enrollment penalty is one of the most misunderstood traps in all of Medicare. Here's how it works. If you go 63 or more consecutive days without creditable drug coverage after you're first eligible, Medicare adds a permanent penalty to your Part D premium. The penalty is 1% of the national base premium for every month you were without coverage. It never goes away. It follows you for life. Let's walk that through with real numbers. Say you delay Part D enrollment for 24 months, 2 full years. Your penalty is 24% of the $36.78 national base premium, which is roughly $8.83 per month added permanently. That might sound small, but over 20 years of retirement, it adds up to over $2,100 in penalties paid on top of your regular premium for coverage you simply delayed. And that's at today's base premium. The base tends to rise over time, which means the penalty amount rises with it. The most common reason people get hit with this penalty? They retired early, had employer coverage that lapsed, didn't realize the clock started, and missed the enrollment window. If you have employer or union drug coverage when you turn 65, get written confirmation that it qualifies as creditable, meaning it's at least as good as Part D. Keep that letter. You'll need it if you ever enroll in a standalone Part D plan later. Now, let's put the pieces together and talk about which combination makes sense, because Part A alone is never enough, and most people need to make a decision between two paths. Path 1, original Medicare plus Medigap plus Part D. You get Part A and Part B from Medicare directly. You add a Medigap plan, often called Medicare Supplement, to cover your Part B coinsurance, hospital copays, and potentially the Part A deductible, depending on the plan letter you choose. Then you add a standalone Part D plan for prescriptions. This path gives you the broadest network access in the country. Any doctor who accepts Medicare accepts you. No referrals, no prior authorization for most services. The trade-off is higher predictable monthly costs, since you're paying Part B, Medigap, and Part D premiums separately. Path 2, Medicare Advantage plus built-in Part D. You use a private plan to deliver all your benefits in one package, often at a lower monthly premium. The trade-off, as we discussed, is network restrictions, referral requirements, and prior authorization. For someone in good health who lives in one place year-round and whose preferred doctors are in-network, this path can work very well financially. Here's my bottom line. For late career workers who are still building savings and need to protect what they have from catastrophic medical cost, I'd lean toward original Medicare with a robust Medigap plan. The premium predictability and unlimited network access matter enormously when health outcomes are uncertain. If monthly premium cost is the binding constraint, meaning you genuinely cannot afford Medigap, then a well-researched Medicare Advantage plan with a strong local network is a defensible choice. But don't choose Advantage because the TV commercial made it sound free. Do the math on your specific drugs, your specific doctors, and your specific health history before you commit. And remember, you can switch from Medicare Advantage back to original Medicare during the annual open enrollment period each fall. But switching back to Medigap in most states requires medical underwriting after your initial enrollment window. That means a pre-existing condition could result in a higher Medigap premium or outright denial. The time to choose Medigap with guaranteed issue rights is when you first enroll at 65, not after you've had a health event. I focus on Social Security and retirement decisions for the 50-plus crowd. And one pattern I see constantly is people making Medicare enrollment decisions reactively instead of proactively. These decisions are not easy to unwind. Building a 30-minute conversation with a licensed Medicare counselor, your state's SHIP program offers this for free, into your pre-retirement timeline is one of the highest return moves you can make. I'm not a licensed financial advisor. This is general education, not personalized advice. Consult a fiduciary before acting. If this helped clarify the Medicare alphabet, subscribe so you don't miss what's next. Coming up, the Social Security wage cap sits at $176,100 in 2025, and there's a specific strategy late career earners can use to squeeze more benefit out of their final working years before they retire. We're breaking that down in the next video. If there's a Medicare question, or any retirement question, you'd like me to dig into, drop it in the comments. I read everyone, and viewer questions genuinely shape the topics I cover next. This video may contain affiliate links. I only recommend tools I use personally.